It's your boy Pesh, and welcome to another episode of Talk Kidney to Me. Not only am I your co-host, I am also a kidney transplant recipient. I am a patient advocate. I am a speaker, writer, creator, and I'm also the founder of A Kidney Life, a place where we raise awareness as well as empower and educate fellow transplant and kidney warriors to be their own advocates. I'd like to now introduce you to our other co-host, Sarah Eve Schaefer. Sarah Eve, how are you?
Hey, very good. I'll give my introduction. I've spent over 15 years working in kidney disease, from direct patient care as a dietitian to managing dialysis clinics to running national projects in CKD and ESRD in the public and private sectors. I'm happy to be representing dietitians and kidney care professionals, really, as we seek to educate and advocate for the entire kidney care community. We have an exciting one today, Pesh. We've been waiting for this one for some time.
Yes, I'm really excited. As you said, we've been eagerly anticipating today's episode. So yeah, let's get into it.
Okay, so when we think about the hottest topics in the zeitgeist right now, AI is definitely in the top 3. Wouldn't you agree?
Absolutely.
It's everywhere, right? So we're really fortunate to have our guest today, Dr. Severance McLaughlin. And Pesh, will you give us his introduction?
Absolutely. Dr. McLaughlin is the founder and CEO of DeLorean Artificial Intelligence, which produces sentient and semi-sentient systems of intelligence for the healthcare market, among many others. Dr. McLaughlin is one of the top-ranked life sciences and healthcare data sciences scientists globally and is an internationally renowned speaker and author in academic and scientific communities. Dr. McLaughlin, welcome and thank you so much for joining us. How are you doing this morning?
Good. I'm fantastic. Pesh and Sarah Eve, thank you so much for the opportunity to come on. And I've been really looking forward to having this discussion because I think this is the type of discussion that needs to be had with AI and the kidney health community. So looking to get into it.
Excellent, excellent. And I know Sarah Eve, as well as myself, when we've spoken to some of our listeners, they've been waiting for us to expand and introduce the subject of AI. So definitely let's get into it. Now, when we have had guests, Dr. McLaughlin, one of the things, of course, that we start out with is how did you get started and when was the pivot that you said to yourself, hey, you know what? AI, this is what I want to do. I want to create DeLorean. So if you want to give us a bit of a backstory of how you got into this.
Yeah, I've been doing this for over 20 years, Pesh and Sarah Eve. So I was fortunate enough to go to university in upper state New York at Cornell, and I did my PhD in Australia in the early 2000s, and we were looking at factors during the periconceptual environment. So when right around the time of fertilization, and how that impacted fetal placental development, but also postnatal and adult health. Specifically the cardiovascular system, the renal system. So I have a couple papers out on kidney development in fetuses. But at the same time, this was the early 2000s where big data was just coming into vogue. And what that means is that we had the technology in the early 2000s to start capturing data at a, not at a small range, but at an industrial size. And that allowed us to start utilizing data in different ways. So, for example, we started having to utilize mainframe computers to do the analysis on our work. And so at that point, I said, why don't businesses or healthcare organizations use data to improve health? And that was, my early 20s, and that really set the trajectory forward for my career. So fast forward, in 2014, 15, I was the global head of AI for a company called Cognizant Technology Solutions for healthcare. And then I was headhunted to a company called the Capgemini Group, a French multinational. And I was their chief of intelligence, or AI, over all AI for the Western Hemisphere. But we were not utilizing AI as a product. We were throwing machine learning engineers at a wall of data, and we were not addressing patient health. We were addressing things in healthcare such as claims adjudication or bureaucracy. So I just thought to myself, this is not what I want to do in life. I want to improve the actual patient experience, get people better. So I said, excuse my language, screw it, right? Like, I'm going to leave. So I left. I sold my house, sold all my investments, and we put a group of data scientists together for 4 years. And we used the scientific process to develop what now is our flagship product called medical AI. And one of our flagship, if you will, is renal AI. And right now, our technology is now deployed in almost 400 clinics, dialysis clinics nationwide. We've processed 52 million patients. We're the first AI to be biologically validated. What does that mean, right? People get scared of AI, but this means that third-party organizations such as United Healthcare, Innovative Renal Care have shown that our predictions and forecasts of the AI are true and accurate with a confidence level of 95 to 99% using electronic medical records, hospitalizations, fluid overload, lab results, dietitian information. And that's where we are today, right? We've gone through the R&D. We're real, and we're saving lives. As I say, we're making more hugs for people. So
That's incredible.
I love that one. There's a lot there we want to get into, and I think we can, weave more of that into as we dig deeper. I think maybe the first question we should start with is, it seems like AI is moving quickly, right? Like it just seems like it's popping at more and more places. Are we past the tipping point? Is it only a matter of time before AI is woven into all areas of our lives?
I don't think it's as quick as people think it is, right, Sarah Eve?
Okay.
So I think what people have seen now is and you may not be old enough, but some of your listeners will, is in the internet bubble, there was something called Netscape. And that was the first time people could actually touch and feel it. And they called it the Netscape event. ChatGPT and OpenAI allowed everyone to be able to touch AI. And I think it's that event. The math and the science behind this has been going on since the 50s. So Turing, who's a huge idol of mine, in 1954 had machine learning. He didn't have the big data or the pipes of data to flow to actually get utilization out of it, and had to wait 50 years. And unfortunately, he didn't survive that long. But yes, I do believe that is so, right? We're past the point of it will, it could, it should, all those things. And I hear a lot of that at conferences still, but we were saying the same thing in 17 as we are now. And what we chose to do is, heads down, get the work done, get it into clinic, and start saving lives.
I love that. I love that event too, right? Because I think that is when everyone could touch Chat GPT and ask it their silly questions and kind of see it. It did kind of bring it more into the public mind.
Yep.
But it wasn't new. It's interesting to hear how long it's been. It's been in development, and only once we connected with those data pipelines were we able to make it useful. And then you take it to the next level with healthcare. It's fascinating.
It's rewarding. It's an exciting time to be in medicine, specifically kidney, right? And some of the things that we see is, in the CKD portion, if we're able to, 30 to 40% of people don't know they have CKD until they get to an interventional nephrologist. If we're able, with AI, which we do, is to find them in stage 1 or 2 or 3A, and we get them on treatment modality, we can extend their lives for 5 to 20 years. Imagine how many more hugs there is, right? Like, it gives me goosebumps. It's such an exciting area.
Yeah, they're not numbers, right? They're real people. These are your neighbors, our friends, our communities, right? Yep.
And I couldn't have told you that 5 years ago, right? It was like, you got to take risk in life, and nothing worth doing. If it was easy, everybody would do it. And now actually going into these practices and meeting the individuals that are the recipients of it is the best reward possible. It's so satisfying.
Yeah, incredibly. And as a patient advocate, it's great to hear that these strides are being made, and this is just the beginning. Because, to your point, as we walk around this country, and 1 in 3 Americans are at risk for kidney disease, having the capabilities to catch this before people crash into dialysis like I did, it's huge, and it's much needed, to say the least. Now, Dr. McLaughlin, let me ask, we understand that AI produces insights from data subtleties. Can you explain a little bit what data subtleties are, and then if you can give us some examples of that, please?
Yeah, so think of it. So what we did is, our first patent is called Interventive and Preventive Intelligence, right? So we define AI. There's a lot of people out there. Most of the AI you see out there is really analytics, and we had to rebrand to marketing. What we call AI is, does it have the ability to predict something in the future? Yes or no? So does someone,
Okay.
are they going to get worse? Are they going to transition from CKD 2 to 3A? Are they going to crash into the hospital, Pesh? Are they going to have a heart attack? Right? So we know what's happening.
Mhm.
The second thing is, can we do something about it? Is there a next best action?
Mm-hmm.
And number three, can the mind of the AI learn? And the answer is, for us, yes. We're learning maybe at a golden retriever or a chimpanzee level right now, but
Mhm.
huge. We were amoeba probably 6 years ago, but and how we do that is because we processed over 52 million patients, and if you go down to the level of dialysis, there's about 700,000 in the country, right? So 30% or 60% are with Fresenius or DaVita, the other 30% are with independents. We have processed over 400,000 of those patients. Okay, no one else can say that. So because we have the N power statistically. Number two, with the CKD, we've processed, I think, over 4 million of those, right? So Google came up to us a couple weeks ago and said, how did you do this? And we processed the entire population, not a subsample. And that's because of our algorithmic power. And because of that, Pesh, people that crash into the hospital, doctors usually, they're like, well, we didn't expect that, but we have the capability of knowing that before the doctor does. Now let's get down to some real world examples. So we have a partnership with Innovative Renal Care, and we're deployed at their 230 dialysis centers. We reduced their hospitalization rate by 27% within 90 days for fluid overload. Right?
Damn.
Yeah, I mean, it's you can't argue with the numbers, you can't argue with the things, but it was giving the clinicians, the nurses, the dietitians, and the social workers all the tools they needed to know to identify those people that could be crashing.
Are you pulling the data from the dialysis flow sheets, right? It's kind of real time, or what's the lag on that?
Really good question. So it depends. So we say real time. We have the capability to be real time. And as Sarah, you probably know better than anybody, and your listeners probably know better than I do. So we, for our base model, asked for 90 data attributes. We need 60 of them for the base model to work. We always love more because we're greedy for data. And so that comes, and those data attributes could be in the EMR, right? That could be Niacin, it could be Constellation Kidney Groups. It could be stationed in, unstructured text from the nurse or from home health or from the dietitian or social worker. So we pull all of that in, and that goes into the model. Now, some of the data points come in once a week. Some of them come in 3 times a week. So it runs whenever the data comes in, but blood work comes in once a week, right? So you can't. There's no point in running the blood work, the next day.
Sure.
But it's really interesting when you look at it, and now we have the capability of looking at those facilities that are doing really well, when the whole spectrum of individuals are working together. So the social worker, the dietitian, the charge nurse, the nephrologist, the change is unbelievable, and it just gives us that the extra capability, and it allows all of them to practice at the top of their license.
Yeah. I like that. I like hearing all the different, areas that you're pulling data from, as opposed to, right, I think a lot of CKD and pop health, we're looking at claims data, which is, right in arrears, we have wait time or EHRs, and also pulling from the notes and things from the interdisciplinary team. I can see how you're able to craft like a real picture of what might happen.
Yeah, and then we reintegrate either into the EMR, so it's at point of care.
Okay.
So if you So when you're at some of our clients are insurance companies, so they don't have an EMR, right? So we integrate into the care management systems, their medical directors but the biggest bang for your buck that you get is point of care. So at the nephrologist office for CKD or at the dialysis center with the EMR, and when that windows pops up, it gives an alert, right? Or please do this or whatnot. Now it's always up to the physician or the nurse or the licensed professional to take the advice or whatnot, because we'll never replace those individuals. And I need to be clear about that. But the capability to be there. So you see some of Somatis was in the industry, right? And they're a care management company. And the challenge for them is being at point of care with the nephrologist. Another, if I can, I get excited about it.
Sure.
Another example of this is people that miss treatments. Now, people miss treatments for a whole variety of reasons, right? Life gets
Sure.
in the way. It's a big change. And Pesh, you probably know
Sure.
this better than anybody, right?
Sure.
And to me, this is like you only know day of, right? So you come in,
Hmm.
the nurse, the social worker, anybody on here's calls, see if they're okay. But now we predict 75% of the people that won't show up a week out. So now,
Wow.
yeah, so if we can't solve all the problems, but if you have your social worker and your nurses, your techs calling them and saying, "Hey, is there an issue that we should be aware about that we can get you?"
Yeah.
This one is mobility, right? So is there an Uber Health? Is there a community church that can give the ride because their family's out of town? 'Cause,
Sure.
getting that fluid off is
Wow.
really important. Yeah, it's things I didn't even know or think that could impact the health, but it's a successive. If you get them on the regular treatments, right? Like you're not going to have
Yeah.
extra
But you could
treatment.
get out ahead of that, right? And be pro. I
Exactly.
mean, I would love a list of who might not show up next week
Exactly. It's so
to be able to support them and right solve those problems before they have them. They feel cared for. They get the treatment. They prevent a hospitalization. I mean, it's
yeah, and there's a white paper coming out in I think 2 weeks, and it shows again we couldn't have said this 5 years ago, right? Like that
Mhm.
all these results would happen, but they're clearly defined, right? And then there's a huge cost avoidance for the insurance companies and the government, and again the major metric is literally like more hugs with family, right? The survival rate of dialysis is what 50% at 5 years, right? And
Hmm.
the hospital that chips away at it. So getting that in there is really important. So
Yeah, that's incredible. So it brings me to a thought. We had one of the initiatives for National Kidney Foundation, um, as far as advocacy goes, is of course kidney screenings. Um, Again, due to the sheer number of people that are at risk for kidney disease and the 90% of people that have kidney disease that are unaware, is with this AI technology, with all the labs, with all the data that's being put in, this you're basically doing the screening and alerting these doctors and caregivers like, hey, this person's at a stage 2, here's a little red flag, or stage 3, here's a red flag. Is that how you're seeing an additional benefit to this, is people aren't waiting again like I did till the very end?
well, I mean, I think so. From a tactical standpoint, we are at end stage renal disease, right? In dialysis centers, and we're
Currently,
in
right.
that life, right? And then and increasing the quality of care. At the nephrologist level, right, we're moving up the value chain. We're at point of care,
Right.
and we're holding them there. Something the technology that that people don't know about right now is unknown patients, and so
Mm.
this is fully available right now to all of our clients. So it's usually larger medical groups or insurance companies for this one. And what it does is it scans the population, and it looks for people who could have CKD or hypertension or cardiovascular disease, and it pulls them and it says, "Hey, the machine thinks that these people have CKD." And those people will rank from 100% probability all the way down to 0.01% probability. And
Hmm.
obviously, the physicians pick where to cut off, and then you just send them for a urine dialysis. I mean, I'm sorry, urine albumin test just to check, right?
Mhm.
And
Sure.
it's cheap, right? And so we have an 89% accuracy on doing that.
Hey,
It's very powerful. And the second thing the machine does is it not only tells you, hey, we think it has CKD and you should do something. It then tells you what stage of CKD or ESRD you're in. So the interesting thing with our largest client was the majority of them, like biology or how things work, is they were in stage 3. When you
hmm.
people go to a nephrologist, we see stage 2 and 1, and once we get them on treatment modality, we can hold them there from 5 to 15 years. The really scary thing was there was a population that was in stage 5 and 6, and they should be on dialysis now. And when they crash,
Mm.
and this is you, Pesh, basically, when they crash,
Yeah.
crash for a while, right? How long were you in the hospital for before you went on to out of acute dialysis into a center?
Oh, wow. I was in Australia and I was in ICU for a week.
Yeah,
And then I was doing dialysis every day, I believe, until I got back to the States. So that was for 2 weeks. And then I was on my Tuesday, Thursday, Saturday schedule.
yeah, and that those people again, there were like 1,100 of those, right? So to put this in perspective, our largest client, from an epidemiological point of view, should have had about 6 million CKD patients. they only knew of 2.2. So it was a delta. So we were able to find another 2.8 million, right? With that varying degree of probability. Now that doesn't add up to 6, but it's a whole lot better than what they had. So again, it's knowing is half the battle. And then did the same thing for cardiovascular, and the majority, like you would think, that we found were hypertensive, right? The gateway to cardiovascular disease, and we'll go into kidney disease in some instances. There was a smaller population that was in I-25, which were ticking time bombs for heart attacks. So the ability to know that before the crash happens, from a healthcare point of view, but also a cost point of view, is huge.
Yeah, and so speaking of the broader point, that's the question on kidney screens is, if we do what we're told, which isn't always the case, as I know personally, we're supposed to get a physical once a year.
Yeah.
So in that physical, we do the blood draw with the metabolic panel and everything.
Yep.
But if it's not always, I guess, not every doctor is going to look at the creatinine or the GFR on that metabolic panel, right? So I guess the vision is to take these yearly tests that everybody is supposed to take and get that CMB and other lab work and start flagging different things.
Well, actually, we don't use labs, Pesh, for the unknowns. We use it for confirmatory and next best actions. So again, AI is challenged in every turn, right? Doctors have challenged us. Oh, there's no way you would know this. And so we said, okay, well, let's do a side by side of what you can find and what we can find. And they were relying on labs. And so first of all, good science and anybody that wants to do better and use it's common sense, right? You should be checking kidney function by the labs.
Right.
And if you're elevated, you have a reason to bring them in for either further tests or, if you have a low GFR, but the person's 90, right? Common sense needs to dictate that's, probably not a huge risk. But, if you have a 35-year-old, then, we're talking a different story. So what we found out when we did a side-by-side comparison is the people that were checking the biomarkers, they did great work, right? They found patients. But we found 47% more, right? Because we're not using that.
Damn.
And it's those. And so I have an issue because some of these organizations, these insurance companies, they're not using this technology. And that 47%, or you, Pesh, if we had found you before that, how would that changed your life? And how many people? I'm kind of getting a little bit probably over my skis, but we had conversations with not the largest, but one of the top 10 insurance companies in the US talking about this very aspect. And the insurance company CMO asked 2 questions, like, are we being recorded? I said, no. Actually, 3 questions. Can I invest in you? And we said, no. And number 3 is like, we won't do this because you may not be on our plan next year. So if we find you in stage 2, why would we want to spend the money? And that's the reality of our healthcare system, right? Like,
wow.
So when we think about that real world application, right, we talk about point of care, we talk about payers, like who in the kidney care healthcare community is most excited for AI?
Oh.
Is it the docs? Is it
the docs? So our docs, the younger docs. So we didn't know, right? We were a little bit like, are they going to think we're crazy? Are they going to think we're trying to come for their jobs?
Sure.
Worried. In our first American Society for Nephrology meeting, the booth was lit up, right? All the young docs come over and they're so excited. Some of them are probably gamers and tech geeks and Apple fanatics. And so, and then when we implemented innovative renal care, we did a really good job engaging the clinical folks, from everybody, right? Social workers, dietitians, RNs, techs, nephrologists. And we started off with, what do you think of AI? And there was some bias. There are people saying, it's going to take my job. It's an alien. And now we have people that were the biggest naysayers, like, I don't know how to do my job without this. This makes my job so much easier. It's not a big lift. I walk in on my shift. I see who my challenges might be and who I can make a difference in. We have a nephrologist in New England, Dr. Thursby, who says, it's spot on, right? He's like, and it's not the people that the people in the red, right? Because you can do better with them. But it was the people one stage below that they spent more time rounding on those. And then they went down to a lower risk level and a lower risk level.
I see that.
And
And
then,
that's something sorry, go
sorry.
ahead.
And
No.
now the big thing is, so we're moving up the value chain and we're deploying now right into the nephrologist's offices.
Okay.
And so now, we've done a really good job at ESRD. Let's go up the value chain and stop the progression or slow the progression, retard the progression as much as possible.
Yes.
Sure. I was just going to say, we talked a little while ago about, right, staffing shortages, nephrologists, nurses, and wondering if AI could, in fact, kind of lighten the workload, maybe, workflow optimization or documentation. But it sounds like it already has that capability just by guiding them to where they should put their resources or their time.
Yeah,
Are
well,
there other ways
absolutely.
that AI can help with, that kind of workload and the provider burnout, so to speak?
Well, yeah, so it allows the nephrologist, right, to know where to spend their time most effectively, right?
Mhm.
There's a specific group, and it's weird because it's over, it's biology in action if it's over multiple clients, is that population who is basically PESH, who crashed and no one knew he was going to crash, so that
Mhm.
they can spend their time there because that's the most valuable. Like if we can
Mm.
prevent the initial crash, we can work towards a treatment plan that can get to normality.
Yeah.
And it allows those doctors to do that. And no human being has the ability to process that much information. It's just impossible. But it allows them to practice at the top of their license. But what I say to people, right, is compare it to going on a flight from Miami to New York. Do you want to be flying on the plane that has just the pilots, just the
Mm.
computer, or both? I want
Mm.
both. I want a fail safe. I want another net. And that brings
Yeah.
another topic as when you're looking at your insurance, right? We all work, we all have to get our health insurance, and it's part of our pay package. We earn it. Now the question is when you're comparing plans side by side, are they using AI to predict chronic disease onset with you years in advance and then being able to treat you? And I think that's going to be a key customer decision coming in the future. It may not be this year, but it's going to
Oh,
come that way where the patients or the consumers or the members are going to start driving that adoption at these larger companies. And
oh,
what
for
will also
sure.
is the
Right? I mean, who wouldn't love that? Who wouldn't love saying, "Hey, you're at a increased risk for whatever in X amount of time, and you can be proactive and take care of it." I mean, that's such a gift.
yeah, it's the gift of life is what it is.
Yeah.
And now we're
Wow.
seeing employers who, they have wellness budgets, right? Like for yoga
Mhm.
or gym, and there's low effectiveness rates on those. But now if you can do something like this and combine it with exercise and things of that nature, there's really an ability to impact their lives as well.
Wow. That's really neat
Yeah.
from the payer side. Go ahead, Pesh.
Yeah. No. So let's take to the next step, right? We've talked about dialysis, talked about slowing the progression of CKD. Let's talk about transplant. So, how do you see AI, and what is your vision that DeLorean could potentially take on the transplant? And one of the things that comes to mind for me is that I've been learning around recently are biomarkers and taking a look at these tests that could look at the biomarkers and subclinical rejection before actually having to do a biopsy that could potentially injure a kidney, cause nephrosis, and things of that nature. How could AI play a role with that?
So funny you say that, Pesh, and for your audience, we didn't pre-discuss this. We will be releasing our transplant AI predictions for the CKD or the nephrologist, hopefully by the end of the year.
Oh, wow.
And we're just so busy, like we're getting phone calls now from transplants, and this is a statistic I learned from the head of transplant at Columbia University. Do you know how many transplants there are or available kidneys per annum by chance? If I didn't know this.
Uh,
I'm sorry.
Go ahead.
There's 28,000 pairs
Okay.
of kidneys. Do you know how many are wasted because they don't have the right person was in contact at the right time or
Around 9,000 a year
yeah.
20%.
is around, right?
Yeah. And so now they're looking at how do we get that better? How do we match the donor better?
Mm.
At the same time, we're getting calls from specialty nephrologists and pharmaceutical companies like, hey, can you help us find people that have a high probability of rejection before and after the transplant? So,
Mm.
Pesh, we're probably going to scratch the surface with the first prediction by the end of the year. This is an area of active research and discussion that we're having with our colleagues in the industry, both the academic and commercial. And what I would say to that is there a there there? Yes. and it's not theoretical. We're starting to work through the process of what we could do. What I would say the end game is, it'll be better than what it is now, but I can't tell you what that will be, right? It's a little bit squishy.
Sure.
We know there's a there.
Okay, good, because my transplant that was in 2018, after 2.5 years, it rejected, and I wasn't aware. I also wasn't aware of other biomarkers and subclinical rejection that can be monitored through different testings. And so this is why I'm very fascinated by this entire topic, just my personal experience, and then making sure that other patients know, being a patient advocate, other patients know to ask for these kind of things, to have these conversations with their caregivers, to say, hey, what can I look at? Because as patients, sometimes we only know to look at creatinine. We don't know to look at other biomarkers, and we've just told, hey, it's time to get a biopsy. And I had 3 of those. So it can be very scary. The entire process from diagnosis onward can be very scary and overwhelming. And then when you're faced with rejection, when you think a transplant is the answer to everything and everything's cured, it's not so much the case when you wake up one day and you realize that the kidney that you thought was the answer to for the rest of your life is not the case anymore.
Pesh, I don't even know how to respond. My heart goes out to that emotion, right? That fear and that unknown. Again, I'm a scientist. What I'll go back to is logic, right? I would say the first thing is patients need to start asking their nephrologist, do you have renal AI? And again, it doesn't have to be mine, right? It can be there's other great scientists out there, right? It would be arrogant for me to say that we're the only game in town. But does their nephrologist have the extra set of computational capabilities? The next one is starting to push, right, the different types of organizations, right, the National Kidney Foundation or the NIH or whatnot, to start putting more money into the research and development. We're on our way, but there are individuals probably listening to this that we can't get there fast enough. But we're on a mission. Like, our team is like, we're on a mission. Like, we're on a mission to change health. We're on a mission to change lives. And I can tell you that, in dialysis and CKD, when we do this analysis and we do the next best action, it maps over to SOPs. So everybody on the call knows that everybody's vetted it, doctors have vetted it. But 5 to 10%, it causes the medical teams to have to change their protocols because the machine that they never even thought of. Yeah. So maybe we need to start doing some of the work in that aspect as to are those markers the right ones, right? Nephrology in itself, its practice is numerical at its base, right? It's probably one of the best areas to have started with us, and we did it by accident. But it doesn't mean that everything's been solved for yet.
Sure.
And so I just want to ask, let's go a little bit into the ethical and biases, right? So it's true then, if there's biases in the calculations or in the data that we receive, that'll be baked into the AI. I'm thinking, right, the EGFR that included race for many years that, allowed a lot of African-American transplant patients to have to wait a lot longer or not receive that care. So how do we kind of account for perhaps the biases in data or ensure that we're doing this in an ethical way?
So I think that, people conflate the term biased with ethics. And I think that is the first thing that needs to be teased out.
Good. Well, clear that up for me.
And it drives me freaking insane when I hear
I'm glad I asked the question.
It's one of my pet peeves.
Okay.
Is that you have people that are AI ethicists who are saying this. And when they talk about bias, then I'm sitting there going well, you don't know what you're talking about. And you're just pontificating. So AI cannot be biased. The machine can't be biased. What can be biased is the data going into the machine. So data can be biased. Okay, that's a really important thing. Yeah. Now, when we talk about this, when you design models, if you are a trained scientist, there is a process that we go through. At the beginning of the call, I was saying that we put scientists in a room for 4 years. We followed the scientific method, right? This is scientific. My belief is if you let good scientists do their work and not regulate them, they will be self-regulated. The challenge is you have kids coming out of college who's like, oh, I can throw this it's kind of like Jurassic Park, where what's Jeff Goldblum's like, you always wondered if you could, you never wondered if you should, you didn't earn it through the hard work. That's a lot of the things that you're seeing pop up. They didn't earn it through the hard work. We did. So the bias, if you're a good scientist, the bias is taken out immediately because you have trained your model with a proper training population. That should just be number one.
Okay.
Number two is, you talk to these health plans or hospital systems, they say the same thing, right? They're going to go through the AI ethics board, and they're getting the same spiel I'm giving them now. And if there is a bias, right, and we're processing all of their 20 million patients, I turn the question to them. I'm like, the bias isn't us. The bias is who you're insuring. The bias is who you're selling to. So you've got to go back and deal with that, right? Like, but with what the population you have, this is what you're getting. So now take that away. Now, if you look at AI ethics, right, like what does that mean? And I still don't know what that means. Does that mean that we use AI for good and we don't use it to discriminate against people? Well, my response to that is there are laws already regulating discrimination. And so when we do this, we make sure that there are all of the necessary protected classes. We do the analysis to make sure there's no difference. So then people kind of get squirrely there. And then I say, okay, well, let's look at the population based on zip code. There's no difference in sex, race, or any other protected class. But if we bring it down to the track level, which is a sub part of the zip code, now you start seeing some relationships, but they are not caused by any of the protected classes. They're caused by social determinants of health or socioeconomic factors. When you control for those, the relationship goes away. So when you can converse like we're having right now you can start teasing away the problems, right? And you can start dealing with problems that the reason, like African Americans and cardiovascular disease, I think is fascinating. In the 1980s, it was thought it was a genetic thing, right? And now out of Harvard is it's not genetic, right? And there probably is a genetic portion of it, right? And we're also including Native Americans and Latinos in this population. But it's SDOH, right? It's a poverty level, or do they have access to care? Now we start having this conversation with these ethicists. We start using the AI to say, are there deserts? Are there physician deserts? Are there nephrologist deserts? Are there dialysis deserts? And now these are the painful questions that we have to start addressing. Another population that's vulnerable are veterans. Okay, veterans have a significantly higher rate of kidney disease than the normal population. Okay, so now we have to start digesting that out. So
I love that, right? That all the roads are converging back to, right, the social determinants of health come up again and again, and it actually heartens me, right, to hear that even AI is pointing in that direction, right, to address folks' most basic needs, which support everything else, that they need to do in their life.
Yeah, and then the question also is and again, this may be painful to hear, is sometimes the damage is already done, right? There's a certain age group that has been through this, that the number of nephrons that have died due to whatever the SDOH factors may be, right? Like higher fat, higher salt content because it's cheaper, what we can afford. Now the question is okay, we know that. Now how do we tactically deal with this treatment modality, this population? But how do we work backwards, right? Like how do we start, because there's a health aspect, but then there's a government cost, right? Like if we start impacting younger generations, and I'm using diet as the variable in SDOH, we're not going to have these huge costs for a percentage of the population for ESRD, in 50 years but is that an American mindset in government, right? That might be a Japanese mindset who very well, but
well, it's something to think about, right? If we could break that generational chain, right, that would be, if we can do the best with, who we have and their conditions right now, but then change it for generations to come. I really hope that is where we are headed, even if it's maybe a pivot from where we are right now.
Yeah.
Yeah, it definitely goes back to that conversation a little bit earlier, and also, as we said on Capitol Hill a couple of times, which was, the government spending billions on dialysis, on Medicare costs, and a kidney screening costs less than $10 a person. So,
well, I mean, I could tell you, and the other challenge is getting in government, right? We could easily take
That's
$2 billion, I mean, which is nothing, right off the cost, right? We can also tell you which nephrologists are getting the job done. Or even going beforehand, Pesh, to your question, like, people like, oh, well, the doctor and the labs and whatnot. Well, tell me why then, if that's all going well, then the majority of patients don't know they have a kidney problem until they're 3A or 3B and they're at an interventional nephrology. It's because of I don't want to say PCP laziness, because I don't think it is that, but because they're so fast and going through so many patients a day.
Sure.
But they should have been caught, or a percentage of those should have been caught in the earlier stages, and they're not. And so then when you look at value-based care and the dictation from the CMS that, and the CMS should say this, like, hey, we're spending billions of dollars. We want return on investment. We want a healthier population. We want better care for our folks. And that's what VBC is, right?
Mhm.
Pay the doctors that do better well, and the ones that don't, just penalized.
Yep.
But we could put our system in place, and we could rank your doctors tomorrow, right? Like, and change behavior overnight. So.
Have any federal agencies reached out? Do you think there's an appetite for that? Like you mentioned, Google, and has HHS or CMS kind of poked at you yet?
CMS has not.
Okay.
My family is besides myself, had the honor to serve our nation, and for those veterans that are listening, a personal thank you from me for your sacrifice and for our nation. So I have a soft spot for veterans, and I have tried over and over and over to help. And there are people at the VA hospitals that want to do something, but dealing with the U.S. government, from what I've been told by contractors of the U.S. government, is more an art than a science. But we're trying, right? Like, if it was easy, Sarah, everybody would have done it. So,
sure.
That's fair.
What rhymes with severance is perseverance. So, we keep on going out.
That's awesome.
So what are the next steps then? Are the next steps going to continue to be kind of baby steps? Are we looking at like taking a few giant leaps in the next few years? Like, what should we expect as this ramps up?
So I think I always think of things in tactical, what's short term,
Okay.
and then what's long term. So tactically, no one can argue with what our AI is doing is improving lives. It's black and white, and I'll send you the white paper to the both of you, and you can make it available to your readerships, your listenership. Knowing is half the battle. So number one, that's tactical, and we want to be in more clinics. So, we're at Innovative Renal Care. We're working with Constellation Kidney Group in the EMRs and their independence, but there's still U.S. Renal Dialysis Corporation, Inc., DCI, and a whole other bunch. So we're interested there, right? That's a tactical. And we're currently moving up the value chain into the nephrology offices, right? There's 30 to 40 million patients in this area. So in the independents, probably 6 million. So we're moving up there. That'll be happening by the end of the year. By the end of the year, like I told Pesh, we'll have hopefully our first transplant prediction. And again, love to show you the data when we get that.
Yes, sir.
Strategically, I think it's we also have cardiovascular, diabetes, depression, and COPD. So to get those out into the field is another tactical point. Strategically, I think we would like, from a business point of view and from a public health, to be in government, right? Is to be into CMS, as well as Veterans Affairs and some of the larger insurers and employers. The value chain I see is you have patient, doctor, insurance company, employer, or government, depending on what stage of life you are. And if we can impact the employer or whatnot first, that causes a downstream. And we're also speaking internationally. So we're talking to people in Canada, Ireland, the UK, the Middle East, to bring technology to those individuals. So that's all the tactical stuff. The strategic is, how does this embed into, from an AI standpoint, and really productize into a software where it's just table stakes, right? And we'll do more disease states and hopefully catch people earlier, but also move into other areas where, like, for example, workman's compensation, right? Getting people back to work or healthier faster, or working with pharma companies and identifying mathematically, the right drug formation or who are those right candidates for those clinical trials. So those are more the strategic aspects. But I've got a lot on my plate right now. So we're counting it in hugs given or lives saved. And we're pretty impressed with, it just doesn't happen overnight, right? Like it's
sure.
but it's, I like the brick wall because as a scientist, if you can put one brick of knowledge or one brick into the wall of knowledge, I think we put 4 or 5 in there. We're in patent 6 or 7. So exciting, right? It's an exciting space to be in. I'm excited to have spoken to you about it.
Yeah, it's great to know you have a team heads down doing the work, right? Making it happen for all those hugs.
Yeah, exactly. Yeah, they don't come easy. So
No. It's absolutely amazing. Again, so glad we were able to do this. Thank you so much for your time. Can't thank you enough. An amazing conversation. Any parting quote or any parting thought for us, Dr. McLaughlin?
Yeah, I was just thinking that. So the pleasure is mine. Anytime I get to talk about my favorite thing, AI and healthcare, I get excited. But this conversation, Pesh and Sarah Eve, is extremely important. And we need to have more of these. I'm not saying us, and the reason for that is the layperson, the general public needs to understand this isn't scary, number one. Number two is we are doing good. You hear a lot of the bad stuff because it sells newspapers and time, but there are happy stories about hugs out there. And when the layperson or general public is more conversant in this topic, they can start, like you said, Pesh, advocating for their own health. Yeah. Ask your nephrologist, ask your insurance company, do they have the AI? They deserve it, right? So,
yeah, absolutely. And I know I'll definitely be shooting you some emails here as we go down the road. But thank you for your time. And also want to quickly, before we get out of here, thank you to LOPA, the Louisiana Organ Procurement Agency, who's kind enough to donate the studio for use for our podcast. And speaking of donating, if you have not registered to be an organ donor, please do so. You can go to registerme.org to become an organ donor, save up to 8 lives. And also to get more information about LOPA, go to lopa.org. That's LOPA.org. Sarah Eve, how about you take us out of here?
Yes, thank you, LOPA. We are moving through these episodes. We still have 2 more in the queue before we take a short break. So follow, like, subscribe, and tune in to Talk Kidney with me as we continue our education, advocacy, and empowerment journeys. Until next time, you're doing great, and we love you.
Thanks, guys.
Thanks, Ev.
Have a good one, guys. Thank you so much.
All right, take care.
This has been Talk Kidney to Me with your hosts, Sarah Eve Schaefer and Pesh Patel. If you're enjoying the show, hit that subscribe button so you'll never miss an episode.
Follow us on social media at Talk Kidney to Me on LinkedIn and Talk Kidney to Me, that's the number 2, on Instagram.
We'd love to hear from you. Email us at info@talkkidneytome.com or contact Pesh on LinkedIn or through Instagram at @akidneylife. Sarah Eve can be reached on LinkedIn or at saraheve.com. Until we talk kidney again, light and love to you all, and thanks for listening.
The Talk Kidney to Me podcast is for general information purposes only and does not constitute the practice of medicine, nursing, or other professional health care services, including the giving of medical advice. The use of information on this podcast or materials linked from this podcast is at the user's own risk. The content of this podcast is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice for any medical condition they may have and should seek the assistance of their healthcare professionals for any such conditions.